Correct.
And do we log out now or just stay where we are?
No, you can stay exactly where you are.
Okay.
We are now broadcasting.
Okay, great.
You can find Helen.
I really need to put
got lots of people logging on. Hello, everyone. Hi, Helen.
Hi, sorry about that. That just took, I don't know what's going on. I hope it's not this virus that's been coming in from all the academic institutions. No. Hi, Cara.
We're online and we're live.
Great.
So we just,
Hi, Helen.
Hi, Cara. Nice to have you online. Hi,
nice
Billy.
to see you.
Hello, Helen.
Helen, I've briefed everyone. We've tested presentations. All's good. They're only going to share their video when they present.
Okay, and are there presentations as well? PowerPoints?
For Cara and for Dr. Valifasa.
Okay. Okay, and are the other two speakers online as well? Okay, I see. Okay, sorry, I'm just getting the... And I see we've got the structure, we're going a little bit differently tonight. Sorry, I see the time already.
No problem.
Okay, how many have we got online? 41.
Yeah, we've got 90 registrations in total, so we've got a really nice turnout this evening.
Great. Okay, then I think we need to get going because of impending load shedding.
Yes.
So, good evening, everybody. Thank you for joining the Metastatic webinar from Rare Diseases South Africa. Thank you to our speakers, our 4 speakers that are joining us tonight, and also to all the participants that are online. I'd also especially like to thank our sponsors, Novartis, for making this event possible. And tonight, as you'll have seen from the outline, we're having 4 speakers, and we have a bit of a time crunch this evening because some of us have impending load shedding at 8 o'clock. So there is a backup plan if we do happen to go offline before the webinar has finished. So it won't go blank, except for those that will also be sitting in darkness. And I'm just going to go ahead and introduce our first speaker. So Dr. Cara Wright is someone who I've bumped into in the academic circuit. She is a senior specialist scientist at the South African Medical Research Council, leading the Climate and Health Research Program. And she wears a lot of other hats at a lot of other universities, including Pretoria, Nelson Mandela Metropolitan University, and also at the University of Joburg. She focuses really on the environmental health in Africa, including personal solar ultraviolet radiation exposure and skin cancer prevention, which is where she's fitting in tonight as our first speaker tonight. And she is going to be talking about 20 years of research in sun exposure and skin cancer prevention in South Africa. So over to you, Cara. Oh, and please, if you have questions during the talk or comments, please drop your questions in the Q&A. And we're going to take questions and have discussion after our second speaker for, concerning those first 2 talks. So just jot them down in the chat and enjoy.
Thanks so much, Helen, for the introduction. I really appreciate it. It's a real pleasure to be here tonight. I'm going to switch my video off because there's bright light in my face and I want you to rather focus on the slides. So it's an absolute delight to talk about what has been 20 years of my life. I've been working in the field of sun exposure and skin cancer prevention. It started in South Africa. I shifted across to New Zealand to learn some skills and came back and committed to serving society to try and solve the skin cancer problem that we have in our country. So hopefully when I click, so first of all, I think it's good to set the scene. What is melanoma? So it's a serious type of skin cancer that develops in cells called melanocytes, which make the pigment in our skin. And really the exact cause of melanoma is not altogether clear, but there are some risk factors, for example, exposure to the sun and the use of sunbeds. So solar ultraviolet radiation exposure is what is the challenge. Melanoma itself can be treated if it is detected as early as possible. The ABCDs of melanoma in the middle. So on the left-hand side, showing those which would be benign, but asymmetry is important. If there's changes in the shapes, the border, the color, if it's mixed, the diameter, if it's larger than a certain number of millimeters, and then E, which talks to the evolution of the mole or the pigmented spot on the skin. And the risk factors down the side, there's quite a string of them. So fair skin or lightly pigmented skin, a history of sunburn, it's not confirmed how many or by what age, but severe blistering sunburns are linked to melanoma. Excess sun exposure, I've already mentioned, having many moles or unusual moles, and there's certain types, so you should go and have those checked regularly. So then there's the genetics, the family history of melanoma. It's also linked, there's a link with weakened immune system. So a person who's had a transplant, for example, and a little bit of evidence around people who have a weakened immune system from other causes. And then sex and age. Age, obviously the older age group, and sex is typically among males, more so than females. And then I've put two at the bottom, which really link especially to deeply pigmented individuals, and that is the sites of trauma. This is a different type of melanoma to the ones that is typically experienced by people with fair skin, which is called cutaneous. For deeply pigmented skin, it's a type of skin cancer called acral lentiginous melanoma. Trauma is one risk factor, and then also oculocutaneous albinism, although people with albinism tend to get the types of cancers that can be treated, not melanoma, which is lethal, but there's also a bit of a challenge there because people with albinism don't always live to a very old age when melanomas might occur. So what is solar ultraviolet radiation exposure? So here's the sun, and there's a band of rays that come down from the sun. They're broken up into UVA, B, and C. You may have heard about UVC at the moment because everyone's talking about it to try and help disinfect SARS-CoV-2 that causes the coronavirus. But the ozone layer protects us from all of that, and it would be very harmful to us on Earth. The one that we are concerned about is UVB. Some of it is blocked during the ozone hole experience, which is now having some recovery. UVB penetrates to the Earth's surface, as does UVA, and both of these, UVB and UVA, have harmful effects on the skin. So when is it high risk? Instead of saying what are the factors that influence UV, I've tried to make it simpler. If you're at high altitude, so very high altitude, top of mountains, you've gone hiking, shiny surfaces like water and sand which reflect, same as a snowy surface. If you live closer to the equator, if you spend time outside during the middle of the day, especially 2 hours around noon, if you spend a long time outside and you get exposed to a lot of UV, and then if you have fair or lightly pigmented skin and you don't use sun protection, and then outdoor activities, obviously, because solar UV radiation is ubiquitous in the environment. It's occurring all the time. The one that's not on here, which I'd forgotten, and I only remembered a moment or two before, is cloud cover. So cloud is complicated. If it's completely overcast, typically that would reduce the amount of UV coming to the surface. But if there's patchy cloud, it can cause extra UV because there's reflection between the cloud and the surface. So cloud is a complicated one. So some melanoma statistics for South Africa. These studies have actually been going for a very long time. So the earliest one that we've looked into in detail is something from 1966. It was among Black South Africans, and it was in Soweto. And the incidence, the age standardized annual incidence of cutaneous melanoma was very, very low, less than 1 person per 100,000 people. A little bit later, there was a study in the 90s done in Cape Town among white individuals, and you can see that this is a much different picture. And that's pretty much the story through all of these statistics. The same here is data which comes from the National Cancer Registry. Melanoma is much higher per 100,000, up to 20 among white South Africans, and still very, very low among the other population groups. What's most interesting too, and you'll note this in a moment when we talk about where people think skin cancer occurs, where it does occur, typically in people who are white, is on the trunk and the head, and sometimes on the lower limb. But if you look at Black African males and Black African females, it's different. It's a different picture. In fact, it's more likely to occur, because it's a different type, I mentioned earlier, on the lower limb and hip. So where did it all begin for me? It all began with personal exposure studies. We can't create messaging for skin cancer prevention if we don't know what people are doing, how much UV they're receiving, how much UV is experienced in South Africa. So in the early 2000s, did studies on children using very primitive equipment. I'll show you now. Spent a lot of time on a roof in Durban, using a biometer to measure UV. And then this is a great one. This lady spent a lot of time in my childhood home. She's plastered in film which degrades, and I was trying to understand how UV falls on different parts of the body that might be linked to where melanoma occurs. So the instruments have really evolved over time. These are the little plastic things I talked about that was on the mannequin. It was also on the children. Degrades in sunlight, and it really just gives you a total dose for however long you wear it, if it's an hour or for a day. But we've become more advanced. Now we've got electronic loggers. So here we've got readings taken at every half an hour. If a child is filling in a diary, you can see their activity, what they were doing. You can see what they were doing here in black. This first bit there is they were doing fitness at school. The ambient is the amount of UV that would hit the surface. And then the yellow is the modeled UV. So this tells us that there must have been some cloud cover, because if we modeled clear sky UV versus the ambient, some of it's taken away by the cloud. And you can even now get miniature sensors and apps. And none of these I've personally tested, so I would only use these for information purposes and awareness raising. There we don't use this typically in research. So the early work in South Africa was really around understanding the UV environment using sensors. I had a large pool of students who've come through my laboratory, which is under the sky, to understand that UV environment. There's a network of biometers around South Africa. There's 5 or 6 of them. They look like this. And we've used those data in a number of studies. On the right-hand side, you'll see the ultraviolet radiation index, which is really a measure that was proposed by the World Health Organization and the World Meteorological Organization to say when it is very high and risky, it gets red. The metric gets red, and the lower the UV is blue. And this is mapped for South Africa. I was trying to count it earlier for provinces and then realized it's only this is South Africa. And as you can see, this is midsummer, midday, and we have extreme UVI measures greater than 12. So bearing in mind this environment, we did a survey among school children in South Africa. And some of the things that we asked were, did you get sunburnt last summer? And it's important to note, so first of all, more than half said yes. And then we asked them to self-report their skin color so that we could compare whether a child who said they had white or light brown skin had a different response in terms of sunburn to a child who said they had brown, dark brown, and black skin. And there were more children with the lightly pigmented skin, saying that they got burnt. But there were also children who said that they got burnt even with darker skin. So this is peculiar, and it led to another study that I'll talk about in a minute. Another thing that was statistically significant here, that's what I'm highlighting, is using shade. And we tended to see that most children did use shade. There was a slightly higher use among children with fairer, lighter skin. And the use of sunscreen was again higher among children who had fairer skin. Why I'm saying this led to other studies, you know, why is it that a child who says they have black skin thinks that they, or self-reports that they got sunburnt, which they may very well have, is in a skin study that we did among 500 or so adults in Pretoria. We assessed using a sensor skin color, and then we asked them what they thought their skin color was. So the instrument we used measures it on this an angle, so from 55 degrees down to -30, which is very dark. And if you look here, what you would typically see is that as the value, which we're showing here, from very light, whoops, I've got to go back one, very light to dark, you would expect to see a decline in the ITA value. But if you have a look at how wide these boxes are, it's showing us, and then the extreme whiskers on the box are showing us that pretty much people either under or overestimate their skin color. So they really can't relate if you ask them what skin color you are on an unexposed site, which is typically under the upper arm. The same is true when you ask the question about burning and not tanning, burning first and then tanning. There was really a great range in response, even with the skin type range, where you would expect somebody with a -20 who's quite dark brown to not say just burn, not tan. So there's a skewed understanding among an individual about what color am I? It's not linked to population group. And how do I relate to the messages that get put out about sun exposure? So we tried to put a cost to this to try and convince government to invest more funding in it. We used a care or pathways approach. So you could either get a suspected melanoma by a GP and then see a dermatologist, and if it was malignant, follow a treatment pattern process, and each was costed. And the cost was extreme at about 90 to 95 million rand a year. That's for 2015, and we included the public and private sectors. And the money that we could save if we did not have these melanomas occurring could actually cover the cost for the HPV vaccine for the girls in grade 6 or 7, which prevents cervical cancer. So there would be a cost saving if some effort was put into skin cancer awareness. In terms of mortality, we were able to access data between 1997 and 2004. Of those deaths, the majority of the deaths were among white people. Of course, there were also deaths among Black Africans, but this is more related to the proportion in the population. I see I'm on 13 minutes, I'm almost done. These graphs show us the trends over time. Most of these changes are not real changes. So first of all, this is male versus female. Female hasn't really changed. There was a big jump here in male. It's most likely to do with reporting. A similar pattern among Black Africans versus white South Africans. But the main thing is to notice that the rates are different between the two groups. I mentioned before that it's only with the help of the students that you're able to gather the information we need to craft messages for people who, for example, work on farms, car guards, for example. And for them, it's not necessarily the skin cancer risk, it's more cataracts and sun exposure in different sites, and trying to figure out what are the best instruments to use. Is our UV environment changing? And what sun protection measures are best to reduce sun exposure. One slide on sunbeds, because there is a relationship between melanoma and sunbed use. We phoned several hundred salons and spas that advertised that they had sunbeds or tan cans. And the key messages here are these ones: no age restriction at all. So in other words, they allowed any aged individual to use a sunbed, including a child. And that the frequency of use was either daily or every other day, which is completely unacceptable and puts individuals at high risk. And a case in point is this patient. This is her profile. It's a lot of information, but essentially she used a sunbed in her teenage years. She used the sunbed again in her 30s and 40s, and 2 years after the use in 2011 developed what essentially was melanoma, and has followed this horrible pathway, lots of stress. And I just spoke to her 2 days ago, and at this point, when we were writing this up, there was no local recurrence, and I spoke to her 2 days ago, and it's come back. So acral lentiginous melanoma in Black South Africans is our concern at the moment. We're worried that there's late presentation of this type of melanoma, even though it occurs in few individuals. Our professionals aren't necessarily trained to diagnosis, leaving a patient with poor prognosis, a low 5-year survival rate, and we have very little self-screening and awareness, which led the Cancer Association and the MRC to do a study among about 1,200 Black South Africans. And you can see here that Black South Africans are perceiving the same body sites which they would expect skin cancer to occur in a white, light pigmented individual. So they're not looking at the sites which are the limbs and feet and palms of hands, the Bob Marley story of the nail bed being a prime example. And the awareness of skin cancer was really one of the drivers for sun protection, but we don't know for sure whether sun protection is essential for prevention of melanoma in Black Africans. It's probably different. It's probably due to a lack of self-checking. It could be trauma, immune deficiency, albinism, and it is unlikely associated. No studies have been done that have shown that. I was asked to do, this is I think my last slide, debunking of some myths. So this top one is absolutely key. You don't get 80% of your lifetime sun exposure before age 18. That was a misinterpretation of a paper from several years ago. Sunscreen is the best protection against sunburn and skin cancer is also false. There are other means: shade, clothing, timing of your exposure outdoors. Sunscreen can protect you from skin cancer if you abide by the instructions. And if you read the instructions, you'll notice that it actually requires you to use a lot more than what we do. Only people with lightly pigmented skin get skin cancer. That's false. Interestingly, coal tar and coal tar pitch can cause melanoma, and we haven't investigated this. Using a sunbed is safe, false, and a tan protects me from skin cancer, which is also false. So my final messages are really that our research continues. CANSA is the main body driving skin cancer awareness and prevention. There is an organization called the Skin Cancer Foundation offering free screening on the 1st of September, but is this really enough? Knowing that melanoma is treatable and curable, is it a priority in South Africa? And if not, how can we change that? And how can we raise awareness around self-screening? So in the next 20 years as a collective, what can we do together to save lives? I'd like to thank CANSA for our collaboration over the years. The next slide is far too small to be seen. You're welcome to email me for a list of all of the relevant publications I've mentioned today, the abstract of the study, and I thank you for your attention. Sorry for running over time.
Okay. Thank you very much, Cara D. We're going to head straight into our second speaker after that very fascinating talk. And we're going to hold our Q&A to the end. So if you have questions, please pop them into the Q&A box and we'll respond to them throughout the other talks as well. So I'd like to introduce Dr. Willy Visser, who is the head of dermatology at the University of Stellenbosch at the Tygerberg Academic Hospital. And he is also the current treasurer of the Dermatological Society of South Africa, or DSSA. He has authored a number of publications and book chapters, and his particular interest is, of course, medical dermatology, especially dermato-oncology. And Dr. Visser is going to talk to us this evening about melanoma. can I get another one? Over to you, Dr. Visser.
Good. Thank you very much, Helen, and thank you very much for the opportunity to be part of this webinar. And I'm always excited to share and to educate around melanoma, because I think it's such an important topic for all of us to know more about. So what I'm going to share to you tonight is, and I think there's a mixed amount of people on this webinar, and I think mostly maybe with people with a family member or somebody that they care for, or who had a melanoma before. And now if you had the melanoma before, the question is always, can I get another melanoma? And I think a lot of people are maybe not really aware of this concept. So the first thing is, let's start with the good news, is most people will actually not get another melanoma. To be more specific, I think more than 90% of people will not get a second melanoma. But you can also get one. And it usually is that the melanoma that you had before is now coming back. And we call that a recurrence of that melanoma. But also possible is that you get a total new melanoma. And we call that a second primary melanoma. And then the third thing is that you can get another type of skin cancer. Because as Cara very nicely explained, that most of our skin cancers are related to the sun and to UV damage. So let's start on a recurrence. So the risk of melanoma is, and if it comes back after your first melanoma, is much higher if you had a very thick melanoma. And that's why if you ever hear the word Breslow thickness, it is really important in determining the next steps in your management of your melanoma. So if it had a very thick melanoma, that's the Breslow thickness of more than 2 to 3 to 4, then your chances of that melanoma coming back is very high. If it was less than 1 millimeter, then it is usually much lower. If your melanoma ulcerated your primary melanoma and caused a type of open sore, the chance of that coming back is also higher. And if at the melanoma there was already surrounding melanomas in that area, the chances are also higher. And obviously, if it's spread to one of your lymph nodes. So the risk is the first 2 years is the highest. So I always, with my patients, if we reach the 2 year, we must celebrate. Because if your melanoma haven't come back in 2 years, statistically, the chances are much, much lower. And then usually, where does the new melanoma come back, or this recurrence, where does it come back? Usually in the same area. If you had a melanoma on your arm, for instance, usually in that same area, you will see it coming back. It can also be to the lymph node, but it can also be more distant, or it can actually come and become a metastasis to the lung or to the brain, which is now a much more evolved melanoma. So let's talk about this concept of a patient with an existing melanoma now developing a new melanoma or a second primary melanoma. Now, if you had a melanoma, your risk will be 8 times higher than the normal population to get a new melanoma. Saying it in another way, 8 out of 100 people who had a previous melanoma will get another melanoma. And that usually happens in the first 5 years after your diagnosis. And that is why this first 5 years for surveillance is very important. After 5 years, the risk is lower, but it is not getting back to 0. And that's why you always have to have a lifelong follow-up with your dermatologist. What about other and different skin cancers? Usually that we call the non-melanoma skin cancers, and you will maybe have heard about a basal cell carcinoma or a squamous cell carcinoma. And as you've heard in the previous talk, UV radiation is a very big cause for melanoma and also for basal and squamous cell carcinoma. So in people with a fair skin, freckliness, lighter skin complexion, then they are also prone for other skin cancers as well. So what can we do if we have this melanoma and now we want to prevent the secondary thing? Now we have two things to our disposal which is very helpful, and that is lifelong skin examinations, and the second one, which is UV protection. And that UV protection is usually includes sunscreen, but as Cara has also said, it's mostly situated about sun protection behavior, protective clothing, and so forth, and not solely on the use of sunscreens. So what do we do with these lifelong skin examinations? And it consists out of 2 components. The monthly self-skin examination, which you have to do for your life, and then obviously follow-up examinations with your dermatologists. And why do we do this? We need to look at our skin very, very carefully, because we know that if we find a melanoma in the early stages, it is treated much easier and much better and could have a higher cure rate if we leave it too late. So skin self-examinations are very important. Even if you make your appointment at the dermatologist as scheduled, it is still important to check your skin. And what is interesting is that more than 7 out of 10 people will find their first melanoma, the second melanoma self on their body, and not the dermatologist. And that is because every time you go to the dermatologist, you will be educated on what to look for. So it's important that you look yourself. So now, what do we look for to see if we can develop a new skin cancer or a melanoma? Any new or growing spot or bump on your skin should be reported to your dermatologist. Any little sore that bleeds or don't want to go away. Any little scaly rough patch that always stays there. You scratch it off, but it always comes back or it bleeds. Any lesion that grows and looks like a wart. And then any mole or freckle that is changing shape and size. And then another important thing is that anything that looks odd on your skin, we almost say funny looking, should be reported. And this is just 2 examples. The one on your left is a basal cell cancer, a very slow growing tumor that caused you almost no problems in the beginning, but then it starts to bleed and it starts to ulcerate. The one on the right is a squamous cell carcinoma that usually starts with a little scaly area. It grows and it can even form like a horn-like lesion. So how do we do self-examinations? And the easiest thing, you can actually just Google and you will find different videos and different tutorials on how to do skin examination. But mostly the only things that you need is a mirror where you can stand a full-length mirror once a month when you're in your underwear, and then usually preferably actually naked, and then make sure that you look at your arms and your hands and examine that carefully, the legs and the feet, and then you use a hand mirror to check the back of your body. And then you can also do a hand mirror to check the bum area as well. And in this picture, you will see that you probably need 2 mirrors to see that. I'm going to show you the next picture, and the only difference here is you actually need a committed partner or a carer to carefully also look at the back of your body, because that's the most difficult part to see. And as Cara has also said, that most of men will develop the melanoma on their trunk area, and the back is a common site. If you're a youngster, or if you have now, everybody has a selfie stick, I think that can also be very helpful to take photos of moles on your back and monitor lesions. And I think the next speaker will also tell you about certain apps that are available, that you can take photos of certain lesions, track them, and the MiiSkin app is also endorsed by CANSA. Then I want to show you a concept that's also been demonstrated by Cara, but most people, 70% of people with lightly pigmented skin, gets a melanoma that we call superficial spreading. So that's the one that starts as a little freckle and then it changes. And I will show you more examples of that. But this 5%, which we call acral lentiginous melanoma, that's melanomas of the nail bed, the feet, and the hands, are actually the most common melanoma that we get in South Africa. And that 70% of melanomas that people of darkly pigmented people will get will be acral or hand and foot melanomas. And all these messages that we have for melanoma is very, very based on educating people with fair skins. And we in Africa should focus our message also to people with darkly pigmented skin and to make them aware of that. So that any person, if you have a fair skin or darkly pigmented skin, can get a melanoma on the hand, feet, and nail bed. But it is more statistically in people with darker skin because they don't get it in the spots that are sun exposed. So make sure any darkly pigmented or freckle on the hand, feet, nail bed, or an ulcer in that area should immediately be biopsied by a dermatologist. And in conjunction with the MRC and CANSA, we actually have driving now a campaign where we have a slogan saying feet up, thumbs up, high five, enforcing that message of look at your feet, put your hand up and look at the palm of your hand. Take a look at your thumb and all the other nails, because it's so important to make people aware that we can get it in all those places. We did a small study at our medical students, and I'm the one that teach them dermatology in their 4th year. And then we asked the 1st year doctors about melanomas in pigmented skin, and all of the knowledge that we tried to share with them, they forgot. And they forgot to check the nails, the hands, and the feet of patients who are prone to melanoma, especially in pigmented people. So now for the next minute, I will talk about suspicious pigmented lesions. So that's a little lesion. Maybe you had a melanoma and now you think this could be a new melanoma, or this is a freckle on your body that has changed in any way that you don't know. So Cara alerted to this, but we use the A, B, C, D, E. So the asymmetry of a lesion. So if you draw an imaginary line through any of your freckles and it doesn't produce the same picture of one of the other sides, then it's an asymmetrical lesion and you should be carefully looked at that. The border, if it becomes scallopy or it grows out in an area, the color, usually if it have more than 2 or 3 colors, it's usually light and dark brown, and if you get a very dark brown or even a black color, it is worrisome and you need to check that mole. The diameter, usually if you take that old pencils with an eraser at the back, if it's more and bigger than that, just watch that mole and track that mole, that you can see if there's no changes. And then the E is for evolving. So that means a lesion looked like this 6 months before and it's now getting bigger. We don't want that for any pigmented lesion, and you should report it to your doctor. The last concept I want to explain to you is what dermatologists use a lot, is the ugly duckling sign. It means I have numerous moles. And as Cara also said, patients with numerous mole or funny looking moles are more prone to getting melanoma. So what will be the melanoma in all those other moles on my body? You look for the odd one out, and that we call the ugly duckling sign. So if you look at this panel on the left-hand side, you will see this patient has numerous moles, but they all look a little bit funny, but they all look the same. And that's the family of moles on that patient. But the one that is standing out, that's the ugly duckling. That's the one that the dermatologist will probably biopsy or carefully look at. If you look at the panel on the left, you will now see that this bad mole in the one person is now looking at the family of mole in the other person, and that the odd one out will be this small one that needs more attention and further evaluation. Again, just to show you, this is the type of moles that the patient have, different sizes, but the one that is different is this one. In this patient, you will see 2 different families, and the odd one out is now the lighter one. And I think this is the most important one, the lonely mole, the one that just comes out and there was nothing before, and that's the one that will be biopsied. Just to show it in a patient, you can see different moles in this patient, probably 2 families. There's light brown ones, and then there's more darker brown ones. But can you see the ugly duckling? And that's the one that fulfills the ABCDE criteria. And this one a little bit more difficult, but you can see the light brown, maybe with a rim of darker in all of these moles. But the one that looks different is this one that is uniformly dark. So if you go to your dermatologist, if you had a melanoma, you will usually be seen every 3 months for 2 years. Why for 2 years? Because as I said, that's the time that we know that a melanoma will come back after your previous melanoma. So 3 months for 2 years. After that, usually 6 monthly, up to the 5-year time where we know now the chance of a new melanoma is also getting less, but always every year, lifelong after your melanoma. What will a dermatologist do differently? Well, they will examine you from head to toe, but we have special equipment and light and dermatoscopes which enlarge the moles, and we can look at specific patterns, and we even have equipment now with artificial intelligence that makes us decisions about these moles. We can track your moles on your body, and we can make sure that we catch them very early. Please note that if you feel uncomfortable checking your own body and you don't know how to do it, and to examine your lymph nodes, or you have poor eyesight, or there's anything that inhibits you for examining yourself, please bring it onto the attention of the dermatologist. We usually have good ways on how to limit that problems. So at this time, I hope I didn't make you more anxious, but I think it's very normal to feel anxious. As soon as you're aware of this horrible thing, melanoma, and you maybe had a melanoma, and now I tell you you can get another one, you become over anxious, and any little thing on your body that is new, you think is a melanoma. And I always think that's fine. And for my patients, I always have an open door policy. If a melanoma patient wants to see me and just show me a little new thing, it's fine. With time, you get used to that. And with time, you also know that I am empowered. I know I can examine myself. I know what to do. I know my dermatologist will take care of me and check me out. And just that way of I know what to do will make you feel much more comfortable and empowered to go forth. And the most important thing as well, to protect your skin and your family from the harmful rays of the sun. And I think the message is that if we catch this melanoma, even if a recurring melanoma or a new melanoma, very early, then we can treat it much more successfully. So I think we have two very important tools that we can utilize, and that is lifelong skin examinations by doing it monthly ourselves and going to our dermatologist regularly and protecting us from the UV rays. By that, I thank you. Thank you very much for that opportunity. I am in an academic practice and I work at Tygerberg Hospital and Stellenbosch University, but I also consult virtually through a platform called Dr. Derma. You can just Google that and find my name there. And I also do practice at a private practice in Milnerton Mediclinic in Cape Town. Thank you very much for your time, and I will more than likely take any questions from your side. Thank you very much.
Thank you very much, Dr. Visser. That was a very informative and practical presentation, and very appreciated. There's no questions currently on the Q&A as far as I can see. And I have one question that I'd like to ask quickly before we go on to the second half is, and it's to yourself and it's to Cara D. I'm just asking about the sun in Africa and South Africa. Is it hotter here than in Europe?
I would ask Cara D to first answer, because she will have the academic answer, and I will tell you the huisgenoot answer.
Okay, so first of all, we have to remember that we can't feel solar ultraviolet radiation, all right? So it's not anything to do about heat or feeling hot. You can get sunburnt in Pretoria in the middle of winter in July if you spend 2 hours outside and you have fair skin around the middle of the day. And my husband is good testament to that. He wears sunglasses on the side of the hockey field or Astro, and he ends up with badger eyes because his face is sunburnt and he's just got these white things. So it's got nothing to do with temperature. It's got to do with the temperature is the infrared parts of the electromagnetic spectrum. The UV radiation is different. We can't feel it. That's why we can get burns on windy, coolish days in summer. And in terms of Africa versus Europe, it depends very much on the latitude. So if you think of the antipole of where we are in South Africa to its sort of inverse site in Europe, it's probably a mountainous area. It's not a coastal site where people are going to spend a lot of time outside. It might be a cooler environment. So I think there's a number of different reasons why the UV exposure is different. The levels themselves are very much dictated by the latitude and altitude.
Yeah, and I think the message from a dermatologist is, if we get that question, we always say, remember, living in Africa, you are constantly exposed to UV rays, winter and summer. Forget about the temperature, as Cara D said. And I think the whole message should be, you should protect yourself from UV rays every day, 365 days of the year. There's maybe one argument about June, July, but the rest of the year is still high UV rays. Rather protect yourself from the development of skin cancer and also from the signs of aging.
Okay, thank you very much. We're going to move on to our next speaker, and we're having a little switch around with our last two speakers. So we're going to, first of all, I'm going to introduce Cara Noble, who is the National Relationship Manager for Service Delivery at the Cancer Association of South Africa. She's got an interesting background, training as a social worker and with her master's in HIV and AIDS stigma. And she's worked extensively as a social worker with adults, children and families affected by cancer, and is very passionate in this area. And Cara is going to talk about the cancer patient support programs. You are not alone. Over to you, Cara.
Thanks so much, Helen, and thanks everyone for joining us today. I'm going to just quickly do a screen share. Something that CANSA is so incredibly proud about that we've just launched is our cancer telecounseling service. I think for those of anyone joining here is a cancer patient, I think, or has a family or loved one that is, definitely a very difficult time for cancer patients, not being able to see family members and loved ones oncology did not stop during lockdown. So the few services that actually just kept on running throughout this difficult time, and patients are really feeling quite isolated and alone. And yeah, we have amazing social workers and nurses that have been working doing counseling and support services as part of our daily work since 1931. We are turning 90 next year, and these emotional support services are a huge part of our core offering to the community, and we just weren't really able to do it. So we actually had a 2-year plan in place to get our telecounseling service up and running, but lockdown really just helped us get there a lot faster, just because the need of our patients was so great and they couldn't have access to us as they normally would. So we are so excited that we launched this on Nelson Mandela Day, and we really do want to connect people with hope. And we are so incredibly proud that we can offer this in 7 different languages, which means wherever you are around the country, you could be in a very small town and you're not too sure what to do. You may be a bit quite overwhelmed with a new diagnosis. You're able to contact CANSA. You can either email us at counseling@cansa.org.za or give us a call 0800 22 6622 to make an appointment. We will work on your schedule, make sure we get one of our wonderful staff in a language of your preference and set up an appointment, and we will call you back. We are very grateful to our sponsors, Novartis and Roche, who have helped us make this a real reality, and to be able to offer this service completely free of charge to our cancer patients and their families. Just, it's also very important to remember that I think, as all of our wonderful speakers mentioned earlier, you need the support of your family if you are someone that does have a cancer diagnosis. For an example, just as Dr. Villy said, about having a family member help you out to look at your back and help you monitor the growth or changes within your moles is so, so important. So it's the same thing here. There are a lot of caregivers that have cancer patients at home and are not too sure where to turn and going through a difficult time. And this service is obviously for the cancer patients, for caregivers, as well as family members that are helping and looking after a loved one with cancer. We are really so excited to be able to work and support everyone involved with a cancer patient. We also do bereavement work and end-of-life preparation, which is something difficult to talk about, but it's also something very necessary that a lot of people need support with, and as well as also supporting parents with a child with cancer. Also a challenging journey to be on for anyone. So we're very, very proud about this service, and you can go online. This is our website. It's www.cansa.org.za for more information. And I'll just show you here. If you even go on CANSA's landing page, you can literally just click telecounseling right there, and you can book your appointment straight on our website. You can call us or even email us. So yeah, we're here to offer you support. No matter what the cancer is here to do our best to support you. I'll then just quickly like to share with you a fantastic app that was mentioned actually by Dr. Cara and Dr. Villy that CANSA's endorsed. It's called the MiiSkin app. And I think obviously, as Dr. Villy said, with melanoma and not being specifically a recurring type of skin cancer, but it is important that you are monitoring your moles and their growth. And I think especially when it comes to basal cells, specifically in squamous cell carcinoma, it's very important that you are managing your skin and know what's happening, because obviously you have a much higher recurrence rate. And if you have a look here at, this is just shows you on, so you can go to any app store. You can decide to go, if you have an Android phone, just to Play Store, or you could actually go to your Apple Store, and it is MiiSkin with a double I. And this is the one that you choose. There is a free version and a paid version. And basically you can see here in this one example where my cursor is, how it, for example, tells you the date that, okay, this is how the mole looked. For example, it says here 23rd of July 2016, and then it shows you 1,031 days later exactly how that looks. So obviously it gives you reminders every 3 months. It encourages you to go and check up on your moles and to do your check, but you do need someone to help you. It'll do a full body, a front, a back, an arm. It is really incredible, and it does a really excellent service. And as also was mentioned, this is definitely not a diagnostic tool, but it can definitely help if there is a change. And if you do notice now that after 3 months or 6 months or a year that a mole has changed or isn't looking good, it is recommending you to go get it checked out. It is not advising you that, oh no, you now have X type of skin cancer. So yeah, that's just basically something we just really like to promote, to make part of your lifestyle, and to ensure that as a cancer patient, specifically with skin cancer, that you are taking care of your skin and that you are monitoring yourself. So yeah, that's all from me. And yes, thank you so much.
Cara, thank you very much. It's amazing how technology, that's so much a part of our lives, has got so many really useful applications for our health. So
Yeah.
I'm for one, I'm going to be looking at that. I'd just like to encourage everybody to keep putting their questions, keep them coming in the Q&A. If you've got any questions for Cara or Dr. Visser or Dr. Wright, please keep them coming. And we have asked the speakers to respond in the Q&A as well. With no further ado, I'd like to go to our final speaker, who is Naninki Siboni, who is a skin cancer survivor. And I'm going to let her tell her story. And she's very passionate, and she's got that personal experience. So over to you, please, Naninki.
I know it's a difficult name to figure it out, but thank you so much. To everybody, to all the stakeholders, thank you so much for inviting me to be a part of this discussion and the value you believe I can bring to this topic through my story. So thank you. So the title of my talk is Love Your Skin, and it was inspired by my Melanoma Awareness Month social media takeover on my Instagram page. And you can find it at Naninki Siboni, my name and surname on Instagram, and see exactly what kind of content I put up on my Instagram, just commemorating the month, because, you know, it's a big month for me, obviously. So due to COVID-19, like many others, I didn't have the everyday freedom, you know, to travel and go to the office parks and the farms and the communities and, you know, places where I would normally go. So I took to social media to find the biggest live audience that I could to share my passion with. And in my post, I ended the post with the hashtag Love Your Skin. And something dawned on me that, you know, I could have a better relationship with my skin by, you know, like really paying attention to my skin and making my chances of living a cancer-free life better. And I guess you would probably ask, how could one make their life a little bit better? And that is to simply practice, you know, self-love and self-care, and in incorporating a better and more stringent skincare routine. And in that way, I'd have the opportunity to almost honor my skin by forever being vigilant and, you know, of all the skin changes that I would have. Now, my relationship with skin cancer is a bit of a weird one, because it was my lack of knowledge and, I guess, you know, unfounded stereotypes about Black and white people on the subject of skin cancer that misplaced my better judgment. And it was that same judgment that had me convinced that skin cancer was a white person's disease, and pretty much that HIV and AIDS was a Black people's disease. And it's weird. It's really weird, because never you mind the fact that I had the telltale signs of developing skin cancer, from my constant nosebleeds to my multiple sunburns and my elevated and irregular moles that kept developing and never really got any better. And I couldn't imagine in my wildest of imaginations to ever predict that these would be warning signs of a grim melanoma future, so to say. And really, how could I? Because we were not having the cancer, let alone skin cancer discussion at home, you know, during our 7 colors meal. No, we were not doing that. This wasn't a topical discussion in any Black home, you know. And in hindsight, I think that this was something, I really wish that this was something that young Naninki had understood, because my life was fueled and just engulfed in my love and passion for sports and recreational activities, which had me, you know, exposed to the sun around 80% of the time. And to be honest with you, I was inconsistent with my sun protective, you know, skincare routine. And these actions all contributed to me being diagnosed with skin cancer at the age of 24. Now, oh goodness, you know, thinking back to it, I really, really, really wish that someone had explained to me that being a fair-skinned child and having multiple sunburns could possibly lead to a skin cancer diagnosis, you know, later on in adulthood. I really, really, really do, because I know that I would have taken better care of my skin. Now, here we are. So there's no point in crying over spilled milk, you know, because with the experience that I have of, you know, cancer, you know, to my experience, of course, I'm empowering myself, and I'm taking back that very same love and passion that I had about sports when I was younger, and I'm incorporating that into my life. I'm empowering myself and investing in, you know, better skincare, better overall, you know, care about my health and just life in general. So I want to say to people, just really love your skin. And what I mean by love your skin, I mean that I don't want it to be a, you know, some self-conceited way, but I mean that you take the active steps to preserving your life, you know, and making sure that you're still around to, you know, be a part of, you know, what life has to offer, be a part of, you know, your children's upbringing and experiencing weddings and all kinds of, you know, wonderful festivities. And I think this is something that, because now we're all here together, you can't, you know, especially all the participants, you can't now tomorrow come back and say, oh, well, I didn't know, because I think the doctors and Cara have just given us enough information to really like think about, you know, what skin cancer is and what it can do in our lives. So I don't want anybody to use that as a crutch the way I did, you know, saying that they had a lack of knowledge on the matter. So, I mean, what I really want everybody to know is that I really like to encourage you to, you know, take very simple steps. And the first step would be to love your skin and do something that I did, you know, for the past really 5 years. I used to take pictures of, you know, any skin changes that I had, and I had an album on my phone. And I just kept track of that. So every time I went to the dermatologist, I'd just show them, you know, where, you know, the changes had been and what was developing on my skin. But also now that I'm like very fortunate, like everybody else who's downloaded the MiiSkin app, and I'm using that now to track any changes on my skin. And I'm not punting it, but it's a good app. It's a really good app. So yeah, I just want everybody to know that, you know, the power is in your hands to, you know, take care of yourself and take care of your skin. Just love yourself, love your skin, and be the best version of yourself. And I just want to say to everybody, thank you so much for this opportunity, number one, and thank you for listening and opening your ears and your eyes and your hearts to listening to my story, as well as, you know, a bit of my message. So from my heart and my soul to yours, I just want to say that you are love, you are strength, and you are greatness beyond cancer.
Wow, Naninki, thank you so much. Your passion and your personality is really coming out of every pore in your skin and through the screen. So thank you so much for sharing your experience, and just for being such a positive and amazing, you know, an ambassador for skin cancer. And yeah, and there's a lot of things coming through on the chat saying, Kele is saying she's so proud of you. And thank you for sharing. She's a liver cancer survivor, and she's your good friend. She's so proud of what you're doing. And she says that sharing the knowledge will really help a lot. We've had some other feedback saying amazing presenters. And can I ask all our presenters to come back onto video, please, so we can just open it up for any more questions. I know Dr. Fissa has been responding to them live in the chat. But they have some more have come through now. Most of them are clinical questions and asking if medical aids pay for PET scans requested by dermatologists. And another comment for you, Nani, that what an inspiration. She's beaten breast cancer, and she's a breast cancer survivor, and she thinks you're giving great advice.
Thank you.
Some other questions for Dr. Fissa, if maybe you could answer them on screen now.
Okay.
Yeah.
Well, I'll answer one of the questions, and I think it's an important question. Maybe I'm reading it incorrectly, but it's currently it's the typical question we get about why should I protect against the sun, but what about vitamin D? And I think the most is yes, but two wrongs don't make a right. So we know that we need a little bit of we need sun for vitamin D, but we need a very small amount of UV rays for a very limited time to actually produce the amount of vitamin D that we really need. We always say you can never use the sun for your vitamin D production. In South Africa, with only your exposure of your face, your neck, and your hands will probably give you enough vitamin D. And if you are ever worried or you do have a low vitamin D, it's much more effective to take a vitamin supplementation than to use the sun for vitamin D supplementation. So, and then there's also a question on, my son is 15. He actually got a first mole when he was 5. This year he got another one, and bigger than the first. What can I do? So we know in children we get moles. You can have them either from birth, but they slowly increase in size and in number till you reach about 30, 35, and then you don't get any new moles. So in children, it's important, new moles will develop, but a new mole should never enlarge out of proportion out of the growth of the child. Melanomas in children are very rare, but it can happen. So just the normal rules are following up a mole. If there's a strange change in that mole, different to the others, or the growth is out of proportion, then it's something to be worried about. Does medical aids pay for PET scans requested by dermatologists? So dermatologists don't request PET scans. PET scans are requested by the oncologists. So you always see your dermatologist for the diagnosis of a melanoma and for your follow-up of a melanoma, and the dermatologist will be the one to refer you to the oncologist if necessary. So oncologists don't check skins, they don't examine you, they don't spot new moles and so forth. You will be referred usually from your dermatologist to a surgeon or to an oncologist for a specific purpose. And there was another question that I think could be very important, and that's why we have all these newer therapies for melanoma, like immunotherapy and targeted therapies. And why is that so expensive? Well, because they are so new and they're so targeted and they work so specific. It takes years of development, and those medications are very expensive. Why don't medical aids pay for them? I will also want to ask that same question, and maybe this is the forum for me to say, I think we as a society should be very stringent about fighting for paying for certain medication that we need. We find that in all types of spheres of medicine that we need, if there's medication available for your specific condition that is proven to work, we should be very, very adamant in asking our medical aids to pay and refund us these medications.
Okay. Thank you very much for getting through all of those questions. There are a few more that's come through that maybe some of the other panel would like to answer. Is how early on in life should we apply sunscreen on children? Maybe Cara or Cara D?
Oh, I'm here. I'm typing, and I don't know whether to type or speak. It's
Sorry.
confusing. Well, first up, really is not encouraged to put little ones in the sun. Infants especially, you know, small ones, we really want this very delicate skin. We really want to try and keep little ones out of the sun. I know that I remember being encouraged to put my child in the sun because she had I forget what it's called now, the thing where you look a bit yellow. I can't remember what that.
The spray tan.
No,
Jaundice.
Jaundice.
Oh,
Jaundice.
Okay, great.
Yeah, no, jaundice. And yeah, it was concerning to me because I was just trying to write a response now, and it's very similar to what Dr. Visser was saying, is that we don't know the time that you are outside or you putting your baby in the sun, we don't know the dose of UV coming down, and we don't know how your skin is going to respond to that. It's different if I put you in a lab and I expose you to a machine, for example, that I know how much dose I'm giving, and it's all very controlled. But when you're just outside or you just put your child somewhere, the risks are high because you have no idea what's happening in your skin, how high the UV levels are. So sun exposure for little ones really needs to be, especially infants, I would suggest not at all. If you do go outside or you're at the beach or something, it's hats and sunscreen if they are going to be in the sun, otherwise keep them in the shade. And then for small ones, I mean, my children know it very well. If you're going to be swimming, it's sunscreen everywhere, reapply at least every hour or every time you've tile dried yourself. And if you can, use alternatives. So for swimming, you can get long sleeves and protective clothing. But really, to protect children from excess sun exposure is very important.
Yeah, maybe just from my side, I will add, as we always say, if your child up to 6 months, you stay in home. You don't take your child outside. It shouldn't be exposed to the sun. That's very easy. And you don't apply sunscreen because they're not in the sun. So that's the dogmatic answer. From 6 months, obviously, always under the shade with extra protection. And then if you want to use a sunscreen because you must go somewhere and there's no chance that you can protect, you still use an umbrella, still use a hat, everything, but then you use a physical blocker, which is probably safer than the chemical blocker. So a normal zinc or titanium dioxide product, and I think in South Africa there's usually ones that say specifically for children, and they should be fine. But remember, you protect with clothing as much as you can of the body, and only the exposed areas get the sunscreen.
Okay, thank you very much. Sorry, so I'm now jumping in. It's Kelly. I see that both Helen has dropped off because I know load shedding has started, and I had load shedding when this started at 7, so it's been a very interesting balance. There was one last question that has come through that I thought was very interesting regarding, should we not have better legislation regarding times visiting beaches, etc., like in Australia? And I'd be interested to see what the panelists thought about implementing sort of stricter legislation, and if you think it's possible in a country such as South Africa.
Cara, you can go first.
Shall I go first? I don't think our constitution would ever permit such type of legislation regulating people's freedom to recreation. What I would like to see our government do is to really be more proactive in raising awareness about sun protection and skin cancer prevention. We've tried with no success for a sunbed ban or a sunbed regulation in South Africa. We've hit brick walls. But to just rely on NGOs and groups to be the main message bearers is insufficient. So changes to the curriculum, for example, where there is a little bit in some of the curriculum in the lower grades about sun exposure, we need to explain there that it's not only children with white skin, and it's not made obvious either. So I think Naniki's story is so important that we need to give the right messages to the right people from an early age in our school system. So that's a Department of Basic Education role. So no, I don't think legislation around beach attendance, it's more about raising awareness and joining together to try and raise awareness for people to understand how to behave when they are outdoors. You're over to you, Dr. Visser.
Yeah, so I totally agree. I think obviously the ideal would not be to legislate that necessarily, but to bring the message forward and to make it very clear for people to know what to look for and so forth. And it's easy messages, as Cara said. And worldwide, there's very nice examples of curriculum that builds this, and also in the school. I know Australia has like no hat, no play, and we see that in certain private schools as well. But it's such an easy rule to have in schools, and to explain the reason for that. So my answer would be yes. I hope there will be more projects running for the prevention, to protect children, especially to ban sunbeds, and to make people aware what to look for, and to have a targeted message, and not based on the darkness of your skin, but perfectly a message that you will know where to look for, what to do, and to help prevent the development. We will never prevent it totally, but to catch it early.
Gee, I couldn't, from one of the NGOs that feels completely responsible for over communicating on government's behalf, I couldn't agree with you more, Cara, with regards to the fact that really a lot more needs to be done with regards to healthcare information and ensuring that South Africans are completely knowledgeable about all the risks of various things. So thanks for that sentiment. It's encouraging, I think, for the NGO sector to know that it is noticed. Well, I think that this has been an absolutely so informative. I mean, I've realized that I'm going to be tracking moles a lot, closer, because I think it is something we just take for granted. And I think also, particularly, life is so busy, etc. And you always think to yourself, oh, okay, I'll get to it. But I think really we've seen tonight just, how early detection and stuff is so critically important for better outcomes. So just a big thank you to all of you for joining this evening. Thanks to everyone who's attended. And once again, a big thanks to Novartis for sponsoring this event. I really do think it has been hugely informative, and really hope that we can do more stuff of this nature in the future. So thank you so very much.
Thank you.
Thank you.
Thanks, and I hope you guys have a great evening further, and I hope no one else gets load shedded tonight and that you all still have power indefinitely. And once again, just a big thank you very much. I hope you guys have a lovely evening.
Thank you very much. Goodbye.
Bye.
Bye.
Bye, everyone.